Hey friends, welcome back to our BNF study series. Today we're moving into part 4 of chapter 1. If you haven't watched the previous 3 parts yet, make sure to check them out first. They'll help you refresh your knowledge before we continue In this part, we'll talk about gastric acid disorders and ulceration, including dyspepsia and gastric and duodenal ulceration. We simply call them peptic ulcers. So grab your notes and let's make this topic super easy to remember. All right, friends, let's start with dyspepsia, a very common condition that many people experience but often don't understand well. So what exactly is dyspepsia? It's a term used to describe a range of upper stomach symptoms that usually last for 4 or more weeks. These include upper abdominal pain or discomfort, heartburn, gastric reflux, bloating, nausea, and sometimes vomiting. Now, these symptoms can happen for different reasons, maybe due to gastroesophageal reflux disease, peptic ulcer disease, a stomach malignancy, or even side effects from certain medicines. But here's something important. In most patients, there's no specific cause found. That condition is called functional dyspepsia. When the patient hasn't had an endoscopy yet, we call it uninvestigated dyspepsia. In pregnancy, these symptoms often come from gastroesophageal reflux disease, so the management follows the same approach we use for GORD. Aims of treatment. The main goal is simple: control the symptoms and, whenever possible, treat the underlying cause. Non-drug treatment. Let's start with lifestyle changes. These are very important before moving to medicines. Encourage your patients to eat healthy and balanced meals, lose weight if they are overweight, avoid trigger foods like spicy or fatty meals, eat smaller portions and make sure to have dinner 3 to 4 hours before bed, raise the head of the bed if they have nighttime reflux, quit smoking, and reduce alcohol intake. Also, don't forget to check for stress, anxiety, or depression, because these can make dyspepsia symptoms worse. Urgent endoscopy is needed if the patient has difficulty swallowing, dysphagia, any gastrointestinal bleeding, or is over 55 years with unexplained weight loss and upper abdominal symptoms. Drug treatment. Now let's move to the medicines part. First, always check if the patient is taking any drugs that can cause or worsen dyspepsia, like alpha blockers, antimuscarinics, aspirin, benzodiazepines, beta blockers, bisphosphonates, calcium channel blockers, corticosteroids, nitrates, NSAIDs, theophylline, or tricyclic antidepressants. If possible, reduce the dose or stop those medications. For short-term relief, you can use antacids or alginates, but remember, these are not for long-term continuous use. Initial management. Let's divide it into 2 types. Uninvestigated dyspepsia. Start a proton pump inhibitor PPI for 4 weeks. At the same time, test for Helicobacter pylori, H. pylori, infection and treat it if the test is positive. In high-risk patients, testing for H. pylori should be done before or along with the PPI treatment. Functional dyspepsia. Again, test for H. pylori first. If positive, treat it. If the patient is not infected, then try a PPI or an H2 receptor antagonist for 4 weeks. Follow-up management. If symptoms don't improve, that's what we call refractory dyspepsia. At this stage, check if there are any new alarm symptoms, confirm whether the patient followed lifestyle advice, and then adjust the treatment. You can continue PPI or H2 blocker therapy at the lowest effective dose, and it can even be used as needed. If the patient must continue an NSAID but can't stop it, consider reducing the NSAID dose, adding long-term acid suppression therapy, or switching to a safer option like paracetamol or a COX-2 inhibitor, with caution for cardiovascular risk. If the patient is on aspirin and can't stop, you can switch to another antiplatelet drug if needed. Patients who've had H. pylori eradication therapy usually don't need retesting unless symptoms come back or there's a specific reason to check again. If retesting is positive, go for second-line eradication therapy. Every patient with dyspepsia should have an annual review to assess how they're doing. If they're stable, encourage a step down or even stop treatment when possible. Sometimes, simple antacid or alginate therapy for self-management might be enough. Finally, if the patient's symptoms are unexplained, not improving, or if H. pylori treatment failed twice, then it's time to refer them to a specialist for further investigations. Getting tired of the details? It's okay. Just catch the main points. If you don't know a term, like alginates, pause and search it now. That's how you really learn. All right, friends, next, let's talk about gastric and duodenal ulceration, also known as peptic ulcer disease. So what exactly is a peptic ulcer? It's basically a break in the lining of the stomach or duodenum. That's the upper part of your small intestine. Imagine the protective layer being damaged, exposing the tissue underneath. The main symptom is usually upper abdominal pain, but patients may also complain of nausea, indigestion, heartburn, loss of appetite, weight loss, or even a bloated feeling. Causes and risk factors. The two most common causes are Helicobacter pylori, H. pylori infection, and NSAID use. That means painkillers like ibuprofen, diclofenac, or naproxen. These two causes can even work together, increasing the risk of developing ulcers. And don't forget, smoking, alcohol, and stress can make it worse. Some people might be more sensitive because of long-term or high-dose NSAID use, or because they already have other health issues like heart disease, diabetes, kidney, or liver problems. Serious complications. If ulcers are not managed properly, they can lead to serious complications like gastrointestinal bleeding, perforation, which is a hole in the stomach or duodenal wall, or gastric outlet obstruction, which blocks food from leaving the stomach. So yeah, it's not something to ignore. Aims of treatment. Our main goals are to heal the ulcer, control symptoms, eliminate H. pylori infection if it's present, and prevent recurrence and complications. Non-drug treatment, lifestyle changes are always step one. Encourage the patient to eat healthy meals, lose weight if needed, avoid trigger foods, eat smaller meals, especially avoid eating right before bed, raise the head of the bed, quit smoking, and reduce alcohol intake. Also, remember, stress and anxiety can make things worse, so managing those helps too. Urgent endoscopy is needed if there's difficulty swallowing, vomiting blood, black stools, or unexplained weight loss, especially in people over 55 years old. Drug treatment and initial management. Okay, let's talk about the treatment plan. First, check if the patient is using any ulcer-causing drugs such as NSAIDs, aspirin, bisphosphonates, corticosteroids, SSRIs, or even recreational drugs like crack cocaine. If possible, these should be stopped or replaced. For short-term relief, antacids or alginates can be used, but not for long-term use. Now, the main treatment depends on whether H. pylori or NSAIDs are involved. If H. pylori positive and no NSAID use, treat with H. pylori eradication therapy, usually a combination of antibiotics and a PPI. If ulcer caused by NSAID use, give a PPI or an H2 receptor antagonist for 8 weeks to help healing. Then treat H. pylori if the test is positive. If no H. pylori and no NSAID use, still use a PPI or H2 blocker for 4 to 8 weeks to promote healing. Follow-up and ongoing management. After starting treatment, review the patient in 6 to 8 weeks. If the ulcer is gastric, it's a good idea to do a repeat endoscopy to make sure it's healed, especially if it was large or severe. If the patient must continue NSAIDs, talk about the risks clearly and review the need for NSAIDs every 6 months. Try to use them only when needed, reduce the dose, or switch to paracetamol or a COX-2 inhibitor if safe for the patient. Always remember, whenever an NSAID is continued, acid protection should be added, usually a PPI or sometimes a H2 blocker or misoprostol. If symptoms come back later, the patient can take a low-dose PPI as needed. If there's no healing or persistent symptoms, double-check the basics. Did they follow lifestyle advice? Are they still using NSAIDs? Did the H. pylori test miss something? Also, think about rare causes like Zollinger-Ellison syndrome or Crohn's disease. If nothing works or symptoms remain unexplained, then it's time for specialist referral. Regular review. For anyone on long-term treatment, review them once a year. If possible, step down or even stop therapy, unless it's clinically needed. And sometimes, just using an antacid occasionally is enough to manage minor recurrences. Feeling like it's too many details again? It's okay. Just get the big idea for now. If a word sounds new, like misoprostol or H2 blocker, pause and look it up. That's how you really master pharmacology. Great job staying till the end. You're building really strong medical knowledge step by step. Next, we'll talk about gastroesophageal reflux disease and Helicobacter pylori infection. So keep learning and see you in the next video.